Hi, I'm Jeanette Domask, and I have over 2 decades in the field of risk management and medical malpractice litigation. Currently, I'm a risk manager at Ophthalmic Mutual Insurance Company, OMIC, where I provide guidance and education to physicians to mitigate risks in their practice. I was previously in a risk management and patient safety role in a hospital, where I was involved in investigations of events that involve patient safety protocol failures. So the title of this presentation is Lessons Learned When Safety Protocols Fail. So implementing and following safety protocols in a surgical setting is important for both patient safety and optimal surgical outcomes. Ultimately, this leads to less litigation. The safety protocols we will be discussing include surgical safety checklists. So when I worked in a hospital, I was responsible for investigating events that involve system and process failures, including non-compliance with surgical safety checklists. And non-compliance leads to surgical events such as the wrong patient, the wrong site, the wrong procedure. And after investigating these type of events, we would have a meeting to discuss contributing factors and root causes that led to the system process failures. Then we would develop action plans to ensure that it didn't happen again. Almost always, these safety protocol failures involved either a failure to understand the protocol, lack of training of the protocol, or failure to follow the established protocol. So I will present actual OMIC cases to highlight how important consistent adherence to safety protocols are for patient safety and positive surgical outcomes. So let's begin. Disclosure, I am employed by OMIC as a risk manager. And the learning objectives of this presentation are to identify factors that increase the probability of errors, encourage staff engagement in safety protocols, consistently use surgical safety checklists, and encourage a culture of safety for favorable outcomes. This is a quote to start us off. Physicians are in a double bind of expectation to be human, just like their patients, and to be superhuman, not like them at all, in never making a mistake and knowing everything. So this quote acknowledges that physicians are also human and they make mistakes. And in risk management, our recommendations are to have protocols in place to reduce or eliminate human errors. And that's the key: patient safety and mitigating risk. So this slide shows the probability of claim in a 30-year career in practice. So in any given year, probability is 8%. But this slide shows a staggering statistic that only 5% of physicians retire without a claim or lawsuit brought against them. It's a sobering figure. So this presentation is formatted to discuss actual OMIC cases that occurred due to safety protocols failing. I have 4 cases to highlight, and we'll discuss the chronology, allegations in the case, expert opinions, damages claimed, and the settlement outcome. And at the end of the case, we'll highlight the risk issues identified and recommendations to prevent similar things from happening. So the first case involves failure to review medical history before treating. So in this case, the patient presented at an August visit. This was a 60-year-old receiving monthly Avastin injections for wet AMD. Patient had uncorrected visual acuity on the right that was in the 20/40 range. Patient missed the July visit due to an illness and then returned in August. The vision at this visit had decreased from 20/60 on the right to counting fingers with a pressure of 44. The cup to disc ratio was 0.3. The physician impression was the vision loss was attributed to the missed appointment in July. The treatment provided was the physician administered an injection of aflibercept. Of note, there was no mention of the high pressure in the physician note. So the pressure of 44 was not mentioned in the physician note. This table demonstrates the pressure readings for the prior 6 months. So that chronology before was on August, and these are the preceding 6 months. So as you see, the pressures were increasing. And of note, there was no documentation of the elevated pressures in any of these visits. So the patient returned in September. The visual acuity was light perception on the right, pressure 45, cup to disc ratio 0.8. The diagnosis was glaucoma. The treatment provided was a paracentesis to lower the pressure. Patient was started on medication and referred to a glaucoma specialist in the practice. At this visit, the physician apologized to the patient for missing the elevated pressures. 5 days later, the patient presented for the glaucoma evaluation. The exam revealed visual acuity of light perception. Pressure was 10, the angle was closed, advanced cupping. The diagnosis was angle closure glaucoma on the right with a severe stage. The plan was to perform a laser iridotomy, and the patient never returned to the practice. So the patient filed a lawsuit against the physician and the practice. The allegations in the lawsuit were failure to evaluate and treat the elevated pressures, negligent injection of the aflibercept. The damages claimed were chronic angle closure of glaucoma, loss of vision, and they blackboarded $550,000 in pain and suffering, including past and future wage loss. So in the physician's deposition testimony, what came out was that the visual acuity and the pressures are recorded in the electronic medical record, but they're not always available on the summary page. And their protocol in the office is the technician is supposed to alert the physician of any pressures greater than 30. The physician admitted that he had never knowingly performed an injection on a patient with a pressure over 30, and he believes that the tech did not communicate this elevated pressure at any of the visits, apparently, because it wasn't documented in any of the visits that the pressures, the 4 visits where the pressures were elevated. The physician ultimately took responsibility for not confirming the pressure before each injection and admitted to being negligent. We had obtained an expert to review the physician's care. The expert opined that the physician failed to timely recognize the high pressure, which over time caused optic nerve damage and loss of vision. We have an internal OMIC reviewer, and the OMIC reviewer also opined that the physician deviated from the standard of care for failing to recognize the elevated pressures at 4 different visits and failed to evaluate and treat the elevated pressures, and that failure was likely the cause of the nerve damage and the permanent vision loss. This case ultimately settled for $360,000. So from a risk management perspective, there was a definite system failure, and that failure was this protocol that the tech was supposed to notify the physician of elevated pressures. The physician ultimately has a duty to either review the history before treating or know the history. And also there was an EMR issue that it is not as open and obvious of when there are elevated pressures. So for this type of an issue, there are things that you can do. You can include in your surgical safety checklist that the tech call out the pressure during a timeout. And a timeout should be done even in an office injection. You can also require that the medical record is brought up before performing the injection. Additionally, you can talk to your EMR vendor and ask that they flag out of range values such as high pressures so that there is an alert in the EMR. But again, you have to look at the EMR to get that alert. So there's different system and process issues they can put in place to try to eliminate this human error. But in this case, the tech clearly was not aware, or any of the techs, because this happened on 4 different occasions. So it sounds like none of the techs were aware that they had to alert the physician of elevated pressures above 30. The second case is distractions in the OR. So in this case, a patient with diabetic retinopathy who had been treated with intravitreal injections presented to the physician with a 2-week history of blurred vision and floaters on the left. The visual acuity was 20/40 on the right and 2200 on the left, with peripheral vision present. The diagnosis was a retina detachment. Prior to the detachment, the visual acuity on the left was 20/80. The patient was consented for a vitrectomy with an air fluid exchange on the left. So surgery was performed at an ASC. There was a vitrectomy done, a retinal detachment repair done, and an infusion of 15% gas. A complication of a choroidal hemorrhage occurred. On post-op day 1, which was a Friday, the patient complained of 10 out of 10 pain and severe headaches for 10 hours that were not relieved by Tylenol. The visual acuity was hand motions at 8 feet, and the pressure on the left was 85. A vitreous tap was done to decrease the pressure to 24, and the gas bubble was 95%. Patient was prescribed medication and given an appointment for the following Monday. So the patient ended up calling the service on Sunday at 6:45 in the morning, reporting that blood kept filling up in the eye. The physician saw the patient in the office and tapped the eye to relieve the gas. There was no note in the medical record to document this visit and treatment, and the patient was ultimately admitted to the hospital for pressure management and pain control. And the visual outcome was the patient remained no light perception on the left. So the patient filed a lawsuit against the surgeon, the practice, and the ASC. The allegations in the lawsuit were negligent preparation of the gas, failure to formulate and implement a proper treatment plan post-op, and failure to keep an accurate medical record. The damages were no light perception on the left, the need for additional surgery, past and future medical expenses, and diminished earning potential and quality of life. So during discovery, it was found that the surgeon involved in this case was performing procedures at an ASC that he rarely worked at. And at this ASC, surgeons are required to prepare the gas. At the ASC the surgeon typically works at, the techs are required to prepare the gas. There were also multiple distractions this day in the OR. There was a new scope that was being used to repair the macular hole. There were 2 manufacturer reps that were present in the OR. The surgeon ultimately concluded that he did not dilute the gas. There was also a lack of a note for the Sunday visit due to computer problems in the office. So our defense expert that was retained opined that the surgery performed was appropriate, the informed consent was proper, but it was below the standard of care to use the incorrect gas concentration. Also, the patient should have been monitored more closely post-op, and the physician should have implemented a proper and timely treatment plan versus responding to the symptoms. and the OMIC reviewer agreed with the opinions of the retained expert. So the case settled for a significant amount of $995,500. So from a risk management perspective, it's really important to be familiar with protocols at the ASCs and the hospitals, and you can't assume just because the protocols at the ASC you usually work at have the tech dilute the gas that at another ASC will have the same protocols. You know, as the saying goes, if you've been to one hospital, you've been to one hospital. You know, all ASCs and hospitals have different protocols and policies and procedures. So it's really important in this case, if you're going to a new ASC, have a huddle in the morning, you know, have a discussion before the procedures. And make it your custom and practice, no matter where you are, to brief with staff. And when you conduct a timeout, part of that timeout should be everyone introducing themselves in the OR. They introduce their name and their role. And if you don't figure out ahead of time, you know, who's in charge of preparing the gas, it should be called out during the timeout what the role of all the different staff members are. And finally, with documentation, you know, if you can't enter a note in the medical records, you make a temporary note and add it to the official record as soon as possible. But very important when you are at a different facility to be familiar with their processes and not assume that they're the same as the facility you normally work at. Case number 3, failure to perform patient identification in the office. On June 29th, a high myopia patient underwent an emergency retinal detachment repair surgery following cataract surgery on the left. Prior to surgery, the visual acuity on the left was hand motions. The patient returned on September 7th and was doing well. The patient had visual acuity of 20/50 on the left. There was no evidence of redetachment, and the patient was advised to return in 6 weeks for an OCT and a bilateral dilated exam. So the patient returned in 6 weeks, had the dilated exam with uncorrected visual acuity of 20/80. And instead of the planned OCT, the patient received bilateral Lucentis injections prepared for a different patient. Of note, the patient never questioned why she was getting the injections. Later that day, the staff informed the physician of the error after the patient had left the office. So the patient was called and asked to return to the office the same day. The insured disclosed that error to the patient, did an exam, and told the patient there should be no adverse effects from the injections. Unfortunately, subsequently, the patient experienced 3 retinal detachments and repair surgeries. So the patient filed a lawsuit against the physician and the practice. The allegation was improper injection of the Lucentis, failure to detect the resulting retinal hole in a timely manner, and failure to take steps to prevent a retinal detachment. The damages claim were 3 subsequent retinal detachments where injection in the area where the injections were given on the left. There were 3 additional surgeries to repair these detachments. There was 1 surgery to remove a silicone oil due to the high pressures. Patient had out-of-pocket medical expenses and ongoing intermittent pain, headaches, and light sensitivity. The defense expert that was retained opined that the bilateral injections were not necessarily below the standard of care. Also felt that the diagnosis did not support treatment with Lucentis, and then finally opined that the patient might have experienced the subsequent retinal detachments notwithstanding the injections, although the retinal detachments did occur in the location where the intravitreal injections were given. So it was hard to say, oh, well, you would have had these retinal detachments even if we hadn't erroneously given you this injection. So unfortunately, defending this case was very difficult. And the OMIC reviewer agreed with the expert opinions, but added a key part of that the patient wasn't consented for the injection. So it is below the standard of care to give an injection when you didn't get consent. That's one objection with the retained expert. I mean, you have to have consent to perform a procedure. An injection definitely requires a consent. So this case ultimately settled for $575,000, and it was split between the physician and the practice. So in this case, we discovered that the way this issue had happened, where the patient received the injection that wasn't intended for her, is the staff had called the patient from the waiting room using only a first name. And there were two patients with the same first name in the waiting room, and the wrong patient walked into the exam room. Now, I get this question sometimes on the hotline, and according to HIPAA, it is okay to use the full name. It's not a HIPAA breach to call out the full name for situations just like this. And you're not revealing any medical information, you're just calling the full name. So again, important to call the full name. Second error that they made was in the exam room, nobody did any second identification, confirm with the patient their name, full name, and date of birth. That wasn't done. The staff didn't verify the procedure with the patient or in the medical record, because if they had confirmed the name and confirmed the procedure and then pulled up the medical record, they would have seen that the patient was there for the OCT. And there was no verification that consent had been obtained because no consent was obtained. And obviously the physician didn't do a proper timeout if one was done before administering the injection to confirm right patient, right procedure. So this practice did have protocols in place that required checking this information. So they had some sort of surgical safety checklist, but they clearly didn't follow any part of a surgical safety checklist. And in this situation, these type of things should never happen. And with a surgical safety checklist, the first step is pre-procedure identification. You confirm the patient's identity and you confirm the procedure. This is before you even get to the timeout. And then during the timeout, you again confirm the patient, confirm the procedure, confirm that you have informed consent, and this was not done. So in this case, definite system protocol failures. The fourth and final case is failure of the surgical timeout. So on this day, the patient had surgery for right eye cataract surgery, and it was scheduled for the third cataract procedure of the day in the ASC. On the morning of the surgery, the second procedure scheduled was canceled. So the third procedure was moved into the second time slot. So the nurse in this case pulled the lens for the patient that was originally in the second time slot. And then during the timeout, the nurse used the second patient's information and lens for the timeout. So a timeout was done just using wrong information. The surgery was performed using the incorrect lens. In the PACU, the nurse disclosed the error to the surgeon. There was a comparison of the intended lens with the implanted lens, and that revealed a significant difference in lens power. The surgeon decided to immediately proceed with the lens exchange. So the surgeon didn't wake the patient up from anesthesia, just took the patient right back into the OR and exchanged the lens for the intended lens. And it wasn't until the patient was fully alert that the surgeon disclosed the error to the patient and the family. So the post-op course, on post-op day 1, visual acuity was 2400 without correction on the right. Patient had moderate corneal edema. Medication was prescribed. They reviewed the post-op care instructions with the patient, and the plan was for the patient to return in 2 days. On post-op day 3, the visual acuity was counting fingers and the pressure was 25. Patient expressed he was angry about the error, and the corneal edema and vision should improve with time is what the physician told the patient. So then they scheduled a 1-month follow-up. So even though the patient expressed anger, they had this error that occurred, they didn't keep tighter follow-up on this patient. They had the patient just return in 1 month. The visual acuity was 20/80, the pressure was 16, the OCT was normal, the retina was normal. Patient did have consistent or persistent corneal edema and was told to continue with the medication prescribed and that they would continue to monitor the patient, but the patient never returned to the practice. Instead, the patient filed a lawsuit against the surgeon and the ASC. The allegation was the incorrect lens was placed. The damages claimed were decreased vision, continuing eye pain, light sensitivity, headaches, and interference with numerous activities of daily living. The expert reviewer that was obtained opined that it was below the standard of care to place the wrong lens, that the second procedure likely caused the corneal edema, but the patient recovered their vision. And they felt that it was probably difficult to prove that the second procedure, meaning the exchange, is the direct cause of the ongoing pain. But it was difficult to disprove that as well, because the exchange was done. It was felt that that's what the cause of the corneal edema was. The OMIC reviewer, agreed it was below the standard of care to place the incorrect lens. Also said that there was a failure to follow the surgical safety checklist, with confirming the patient identity, confirming the lens power. There was no consent obtained for the lens exchange. Now this, when we present this in live presentations, there is a dispute about whether you wake the patient up from anesthesia and get consent before you do the lens exchange, or do you not and proceed with the lens exchange? Some will say, yeah, you don't wait, you just exchange the lens, similar to if the lens had torn during the procedure. You would just exchange the lens and you wouldn't reconsent the patient. There's no right or wrong answer. Some would even go into the waiting room, talk to the patient's family member, get consent from the family member while the patient's still under anesthesia. So there's differences of opinion, but the reviewer felt that the extended surgery time likely contributed to the corneal edema, and that was really hard to disprove, that the corneal edema wasn't caused by the extra surgery. So this lawsuit also settled for a significant amount, $750,000, with a split of 50-50 between the physician and the ASC. So from a risk management perspective, there were definite systems failures on the part of following a surgical safety checklist. So in the first step of the checklist, you identify the patient. Confirm the patient's identity, to patient identifier, the site, you're doing the left and right, bilateral, what the procedure is, and did you obtain consent? Now, with these surgical safety checklists, you can adapt them to your own practice. So if you're dealing with lens powers, you can add that on the checklist. Confirm lens power by comparing to the medical record. The patient might not necessarily know what the lens power is, or compare it to, if it's on the consent, compare it to the consent. But there was just no check to verify that they were doing the correct procedure with the intended lens. And during the timeout, the incorrect information was used. The wrong patient's lens power was used. So that timeout wasn't effective, so we're using the wrong information. And then another, allegation was the informed consent. That's, again, something to think about. If something like that happens, how would you handle that? Well, here is a surgical safety checklist that a task force at OMIC and the AAO put together, and it's specific for ophthalmic procedures. And it mimics the World Health Organization surgical safety checklist. You also might be familiar with Joint Commission's Universal Protocol, and they developed this, the Joint Commission developed a surgical safety checklist over 15, 20 years ago. I think it was 2010. And because of all of these wrong patient, wrong procedure, wrong site events, and so this checklist was developed to help prevent these events from happening. And they contain 3 parts. You confirm the patient identity, you confirm with the patient, this is what we're doing today, this is the side we're treating, this is the procedure we're doing, sign this into a informed consent, you mark the site. And the second key part is the timeout. All team members should introduce themselves by name and their role. If you're in charge of calling out the pressure, you introduce yourself. I'm the technician, and my role is to look in the medical record and call out the pressure. Or I'm the technician, and my role is to dilute the gas. In these different cases, you can see if this had been done, then it would have been identified. It should have been identified before the timeout, but at least by the timeout, it would have been identified which person was responsible for which task. This also calls out that the surgeon and the nurse confirm the lens power. Now that is something that I would definitely recommend to do, in the pre-procedure stage, because you don't want, that should be verified in the pre-procedure, not during the timeout. But it should also be confirmed during the timeout. But you can also add, as they added here, gas is on there. So you orally confirm gas. Sometimes we've had fires in ORs, and you want to confirm with the anesthesiologist when you're using cautery, what you're going to do with oxygen. There's oxygen being used. Turn that off and have that discussion. It should be done before the timeout as well. And then finally, the sign out includes, the counts, and any specimens are labeled and any equipment issues are addressed. But this is a checklist that you can adapt for your individual practice. So you can make modifications to it, but the key is to use it consistently. So from a risk management perspective, why do these errors occur? Well, as we've demonstrated, failure to implement a surgical safety checklist or a protocol, and failure to follow a surgical safety checklist that includes all these areas, pre-surgical verification with the patient of the identity, the site, the procedure, consent, in addition to a timeout. There is often a deviation from these checklists or just going through the motions. Sometimes there's a lack of awareness of what the policies and procedures are, how the workflow works in a specific hospital or ASC. Also, the surgical safety checklist should be done in office-based settings as well. When you're doing injections in the office, these surgical safety checklists should be used. Sometimes there's inadequate training or communication. Sometimes staff fails to speak up about safety concerns or mistakes or errors. There's time constraints, there's system and process gaps, and when there are gaps, these lead to human errors. So the key is to fill those gaps, do a gap analysis, fill in those gaps so that you don't have human errors, because these type of events should never occur. So again, how do we avoid these errors? Consistently using the surgical safety checklist for all procedures, whether in the office, in the ASC, in the hospital, and either institute a protocol using the surgical safety checklist, or if there isn't one developed, discuss it with administration at the ASC or internally at your own office. You want to adapt standard checklists for your specific procedures, your specific setting, your specific workflow. And definitely engage staff. Conduct simulation training with mock drills, similar to what you would do for emergency drills. You conduct these for the surgical safety checklist. And in the hospital where I worked, they identified certain areas where they needed these simulation training drills to make sure that they had compliance with the use of the surgical safety checklist and that everyone knew what was on the checklist and what their role was. So it's very important to do a simulation drill instead of just telling someone what to do. If you simulate, it has a lot more effectiveness for compliance. You want to create a culture of safety so that the staff feels safe to report errors and they speak up regarding safety concerns. So I had a case involving a nurse that was scared to speak up because a surgeon had yelled at her twice before a procedure. And then during the procedure, the nurse realized the surgeon was doing the wrong procedure. And instead of speaking up, she decided not to say anything because she didn't want to get yelled at again, and she convinced herself that the surgeon must have changed the plan and just not discussed it with her. Ultimately, the patient wasn't injured, but they had to repeat the procedure to get the right procedure done. So you want to create that culture of safety. And you want to model compliance and respect for following protocols. So, you set the stage for a culture of safety in your OR. Again, how can we avoid these errors? Assess the culture in your practice or OR concerning safety practice protocols. Is it a culture that is concerned with patient safety? Are there things that you need to adapt or implement to make it more safety conscious? And consider reinforcing expectations with staff. Reviewing the surgical plan. This can involve a debrief before the procedure. It can involve a huddle before the day starts so that everyone's on the same page. Communication is key. So a lot of these things, it's, the surgical safety checklist, but it's also communication. There was not enough communication to prevent these errors. You ask for clarification when needed. You want staff to speak up about mistakes or near misses. And you want to create that team environment. Again, every person in that OR should play a crucial role in achieving a safe outcome. And I've seen situations where the people in the OR are just going through the motions. They're not exactly sure where they're there. They're not sure what their role is. But if they're there, they should have a role. So you want everyone to feel part of the team. You want them to introduce themselves and what their role is in the procedure. And it doesn't take that much time. Even when you're doing an injection in the office, it doesn't take that much time. And we do have a video on our website that a physician has done for injections in the office setting. And it's a timeout video. She goes through the steps that she takes when conducting a timeout for an injection, and it's less than 2 minutes long. And just it saves so much time in the long run, because as we went through all these cases, there were steps that were missed, but in the long run, it takes more time to have to disclose errors to patients and have to do follow-up care. It's time well spent to develop these protocols, to follow these surgical safety checklists to prevent these errors from happening. Because again, these type of errors, wrong patient, wrong procedure, wrong site, should never occur. So again, create a culture of safety that models behavior and prioritizes safety. And in summary, adapt safety protocols that fit your specific practice. Be aware of safety protocols in ASCs and hospitals where you practice. Encourage the implementation of safety protocols. Disclose errors in a timely fashion. Model the behavior you want to see in your staff. Create that culture of safety. And document. In risk management, we always say, don't forget to document. Finally, our resources. We have on our OMIC.com, we have resources for documentation, responding to unanticipated outcomes, surgical safety checklists, example, the video that I just spoke about, and then obtaining and verifying informed consent. And the AAO has recommendations for wrong site task force. They say wrong site, but it also includes wrong patient, wrong procedure. AORN has information, and so does the Joint Commission. Again, you can contact us at riskmanagement@omic.com. We also have online resources that are open at this time, omic.com. And finally, thank you so much for listening to this presentation. I appreciate your time.